Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and this is the second of the two lectures on COPD. And the last one we discussed the basics of chronic obstructive pulmonary disease, and in this video we are going to cover the diagnosis and treatment. Now, if you have landed up here directly, I suggest that you should watch the earlier video first and then come here to have a better understanding. So let's talk about the diagnosis and treatment of COPD. COPD, of course, you know, chronic obstructive pulmonary disease. Now, the first of all, the diagnosis. I think diagnosis is possible. Clinical diagnosis is possible in majority. In chronic bronchitis, you know, the definition is based on symptoms. So theoretically, you should not be needing any test at all. If somebody gives history of chronic productive cough, chronic for 3 months, for 2 years, with no known explanation, then particularly if the patient is a smoker, we make a diagnosis of chronic bronchitis. Emphysema is made, the diagnosis of emphysema is made on certain clinical feature. Patient actually has, the definition of emphysema is based on certain histological changes in lung, but that transforms into certain morphological changes. And lungs are expanded, and if you see the chest, you will see the barrel-shaped chest. So there will be barrel-shaped chest as an indication of air trapping. And plus, it also translates into certain radiological changes. So I think diagnosis of COPD is made on history and on the basic test, physical examination, and the very basic test, X-ray. So diagnosis is usually made on that, but we will discuss other conditions also. Then X-ray chest, PA film is the best film, and I'll show you the features on X-ray which suggests this diagnosis. Spirometry, this is the spirometry, and in spirometry, a patient is usually instructed to breathe in and breathe out into this device, and this is now electronic device. Previously it used to be mechanical, and this machine senses how much pressure one can generate and how much air one takes in, how much air one can push out, and there are some instructions which are given by either the operator or the instructions come on the monitor. So patient does that, and you usually see this clip is applied to the nose so that the air is measured from the mouth. So this is the spirometry. Spirometry is a great test, but it is not indispensable for the diagnosis. Mostly it is not required for the diagnosis actually. This pulmonary function test can give us two important informations. One, what is the predominant type of respiratory disease? Respiratory disease could be obstructive pattern or could be restrictive pattern. So it will tell you predominantly if it is obstructive or restrictive or if there is a overlap. I think second advantage, the bigger advantage of pulmonary function test is that it will quantitate the problem, and you can determine the exact level of respiratory insufficiency, and then with treatment you can follow the patient up and see if there is any improvement. So these two features, and then sometimes we need to do arterial blood gas, particularly those patients who have cyanosis, those who are serious, and those who are at the verge of respiratory failure. So those patients who are admitted for COPD, they need ABGs, but for OPD patients, those who come to us in OPD, we don't need ABGs because the diagnosis is usually possible, and we know they have hypoxia, we know they have some degree of hypercapnia also, but if they're not serious, then we don't go for blood gases as a routine test. This is the X-ray chest. Now just to remind you, I have a complete set of videos called, there's a playlist in my channel called Radiology for Internists. So I have a detailed discussion. There's one complete video on normal X-ray, one complete video on COPD. So I think if you are interested, you could look for that video and you can see that. But here, just basic, you can see this is a case of emphysema. There are two things which you can appreciate. Vertical lung fields are increased and overall translucency, this is increased because there's more air than lung tissue, so this is more translucent, and diaphragms are low and they're flat. You see these diaphragms, they are low set and flat, and this is also rather blunted. You can see this one, and heart size is smallish because in emphysema your vertical lung dimensions are increased, diaphragm goes down. Since heart sits on the diaphragm, normally heart is an oblique structure and it becomes more vertical, so it becomes more or less tubular type. So typically patient with emphysema would have a small tubular heart. So to repeat, increase vertical lung dimension, increase translucency, and flat low set diaphragms with disturbed contour and a tubular vertical heart. Emphysematous bulli, if present, they're not present in all cases. If they're present, they are highly suggestive. Maybe if you, I think, stretch your imagination, maybe you can appreciate one bullous here, because you know you don't see any lung parenchyma here. This is like complete jet black as compared to this one. So there may be a big emphysematous bullous here. If you see the X-ray on the lateral film, you will see that the increased AP dimension is increased. This space is called retrosternal and this is retrocardiac. These spaces are expanded because of increased AP diameter, and then the rest of the changes, the same diaphragm will be low and flat. This is also flat. If you have seen normal X-ray, this should be a rounder like this. So this X-ray is very, very suggestive of emphysema. This is X-ray of chronic bronchitis. In chronic bronchitis, many times X-ray may look just normal, but the basic abnormality is increased bronchial markings, bronchopulmonary markings, because of the fibrosis. You see, this is not very neat looking, and this white tissue is fibrous tissue, and there is little bit of element of emphysema also. Heart is not tubular. So, and sometimes there may be actually cardiomegaly in chronic bronchitis also because of the right ventricular dilatation. So diagnosis of chronic bronchitis is predominantly made on history. X-ray, maybe we say that this X-ray is consistent, but emphysema diagnosis can come from X-ray even if you have not seen the patient. In radiology, CT scan is better. So these days we do CT scans. This is the CT scan of a patient with chronic bronchitis. There's a lot of this white fibrous tissue, and this is suggestive of chronic bronchitis. If you do a CT scan in a patient with emphysema, you can see those changes, and you see these large emphysematous bulli. This one, these one, they are big emphysematous bulli. There is no lung tissue here. It's one massive lung space which has just air, which is not contributing into ventilation. This is like dead space. Now this may not be very visible on X-ray, because when we see X-ray, this part, for example, this will be overshadowed by this normal part lung. So these emphysematous bulli are much better appreciated on a CT. One important CT is that if we can identify these massive bulli, that might actually lead to the surgery. When there is a volume reduction surgery, these bulli may be removed and they might actually help in breathing. Typical blood gases, if you do blood gas in these patients, pH is mostly normal. unless patient develops a respiratory failure or patient is severely hyperventilating, pH is likely to be within the normal range. And oxygen level is reduced depending upon the severity. It would be reduced in all patients with COPD. The severity would vary, but I think it is very unlikely to have normal oxygen pressure in a person with COPD who is symptomatic. So there may be mild to moderate to severe reduction in oxygen in both types. CO2 may be increased. Now this may be little interesting because carbon dioxide is 20 times more diffusible than oxygen. There may be a case who is hypoxic but not hypercapnic. Because of hypoxic hyperventilation, patient may be actually washing out carbon dioxide. So carbon dioxide may be low, but once respiratory failure sets in, then carbon dioxide will be first normalized and then increase. So presence of hypercapnia is actually a very serious sign. We will have a separate lecture on respiratory failure, but based on the fact whether somebody has just hypoxia or hypoxia and hypercapnia, respiratory failure is defined as type 1 or type 2. That is actually a very serious condition. Bicarb level is usually increased because in COPD there is chronic retention of carbon dioxide. Because of chronic retention of carbon dioxide, there is also proportionate retention of bicarb. Now, since carbon dioxide and bicarb both are retained, both will be high, but since their relative proportion determine the pH may be normal. So that's why pH may be normal despite high carbon dioxide because bicarb is also high. Both acid and alkali both are high, so pH may be normal or within normal limits. If a patient has got hypercapnia and increased bicarb level and then pH is acidic, that would suggest acute exacerbation. Because in acute exacerbation, carbon dioxide will increase suddenly because that is very easily retained, but bicarb will take some time to build up. So there will be a situation where there is the proportion between carbon dioxide and bicarb is lost and there is predominant increased carbon dioxide, and that may produce acidosis and pH may become acidic. If you do pulmonary function tests, I'm sure you are familiar with these terms, but let me define them. Peak expiratory flow rate. This is the test which is done with a peak flow meter, Wright's peak flow meter. This is a very simple handheld device. Patient is asked to breathe into that, and that measures the maximum velocity during expiration. So that is reduced. And FEV1, which is forced expiratory volume during first second, that is also reduced. Now these two are cardinal features of obstructive airway disease. And when we test reversibility, and how we do that, we first measure these and then we give patient aerolized bronchodilator in the form of nebulizer, and we repeat these tests. So if there is improvement in these parameters, we call it reversible. Since COPD is predominantly an irreversible disease, so with the bronchodilator we expect improvement less than 15%. If it is more than 15%, that means there is element of reversibility. That means there is element of asthma also. Then this is the new test, the pulse oximetry. This we can very simply measure. It's non-invasive. There is a small transducer that is applied on the finger and continuously give you the oxygen. And this is also very useful, but it's not actually a substitute of arterial blood gas. Spirometry, there's a little more detail. In a normal person, when we do spirometry, so this is the inspiration. The total amount of air is taken in and this is the expiration, and this is the type of loop that is made. In patient with restrictive disease, the pattern is different, but in obstructive disease, you see this inspiration is okay, just like this one, but in expiration, especially this part, because of obstruction, this loop is so much different than this one. This would indicate an obstructive airway disease. But in restrictive airway disease, the loop shape is the same exactly as normal, but only it is in smaller structure. And both phases are small, but actually the morphology of this loop is exactly like normal. It is as if lungs are normal, but smaller in size. I think that is the best way to visualize a restrictive airway disease. And this is an obstructive airway disease. This would be applicable in patient with COPD. Treatment, very important part to be coming. I think first of all, you need to sit with patient and explain. You cannot accuse a patient for being a smoker. You cannot make him responsible for his act. This is inhuman. I think patient needs sympathy. Patient needs empathy. You need to sit with the patient and in a very gentle way, you need to explain that the smoking needs to be quitted. So I think, of course, patient would take some time to prepare his mind, and it's not easy. But you should definitely start working on smoking cessation. Patient might need separate counselor or some aids to quit smoking, but that is very important. What do we expect from cessation of smoking? Maximum we expect is that there will be no further progression of disease. We do not expect disease to reverse because this is permanent structural changes. Bronchodilators and expectorants. Although COPD, chronic obstructive pulmonary disease, is predominantly irreversible airway obstruction, but we do have some component which is reversible. So we give bronchodilator exactly the way we give to patient with asthma, and we can give through inhalers, we can give through nebulizers, we can give with in the form of tablets. But all bronchodilators, beta 2 agonists, theophyllenes, they are given. Since these patients, they have a lot of sputum production, we also sometimes give expectorant. Although some authors, they doubt the efficacy of expectorant, we say because of the chronic inflammation, there is neutrophil in the airways, they produce proteolytic enzymes, they are best mucolytic and expectorant, but expectorants are generally prescribed to help them expectorate so that the airways become patent. Antibiotics. Now, mostly, I understand mostly antibiotics are misused in our society. Mostly antibiotics are prescribed when they're not needed, but patient with COPD, I think your threshold of giving antibiotics should be low. It is best to start an effective antibiotic earlier on. Whenever patient develops an acute exacerbation, a course of antibiotic should be given. Which antibiotic? It should be the one which we know is effective in respiratory tract infection. I might choose an macrolide like erythromycin, clarithromycin, azithromycin, or I might choose a respiratory quinolone like levofloxacin, sparfloxacin, bemifloxacin, garifloxacin, moxifloxacin, so they can be used, or second, third generation cephalosporins, they can be used, and these are the linezolid can be used. So these antibiotics should be used. I think they should be used at the earliest manifestation of acute exacerbation, and they should be used in a proper effective dose and for a proper duration so that they do not develop resistance to these antibiotics. Steroids in patients with severe airway obstruction, those who are at the verge of respiratory failure, a short course of steroids may also be justified. Why so? Because there is lots of inflammation in the airways. Although the inflammation is caused by infection and smoking, and we work on that, but since steroids are very effective anti-inflammatory drugs, so they may be used to immediately control symptoms. A short course of steroids is definitely justified. Of course, long-term steroids is not indicated, but short course is definitely helpful in some cases. Oxygen, in a patient who comes to the emergency, oxygen should always be given because they are hypoxic. Those who have very advanced disease, they may be advised to keep oxygen at home. So this patient will become less symptomatic, and there are studies that with domiciliary use, patients' quality of life improves and patients' life expectancy can also improve. Antitrypsin replacement, to my knowledge, antitrypsin replacement is now possible. There are certain protease inhibitors which are now available, but they're very, very expensive. Those who have this antitrypsin deficiency and they're lucky enough to afford them, they can be offered this treatment. And rehabilitation, you can make your lungs more efficient by respiratory exercises. So I think the rehabilitation is also something we can offer to these patients. Then surgery, if somebody has large emphysematous bullae, and this could be, bullae may be removed, and in that case, remaining lung will expand better and breathing will become better. So I think that is also one of the options, but of course not in all patients. Now, how do we prevent acute exacerbation? I said the commonest reason for admission of these patients is acute exacerbations. And how can we prevent acute exacerbation? First of all, environmental control. These patients should be advised to avoid the environmental factor, which also includes cessation of smoking, avoidance of pollution, bad air, smoke, dust, cold wind. I think this should be avoided. These patients should be given regular vaccinations. Flu vaccination should be administered every year before the winter, typically in October. Every year new shot has to be given because flu virus, they tends to mutate. Pneumococcal vaccine should be given usually once in a lifetime is good enough. Either Pneumo 23 polysaccharide vaccine or these new conjugated vaccine Prevenar can be given. In some cases, both are advised with interval 6 months, but pneumococcal vaccine should be given. But remember, this pneumococcal vaccine will only prevent pneumococcal infection. These patients can have other types of respiratory infections, so we are only trying to reduce the infections, but they will probably still occur. And I think this COVID-19 has become a new reality. COVID-19 vaccination should also be given to everyone, but particularly those patients who are COPD, and they should also get regular boosters every 6 months. Early use of antibiotics. I think judicious use of antibiotic may be helpful. So complication with COPD, acute exacerbations of chronic bronchitis. Why should we try to avoid this? Because this is what pushes the patient into respiratory failure and hospitalization. And every acute exacerbation will increase the lung damage, and there will be more and more lung disease. And cor pulmonale, that means with advanced lung disease, there will be pulmonary hypertension, right heart failure. So that is another complication. Pneumothorax, because these patients are using their accessory muscles and lungs are already weak, there is a possibility of pneumothorax. One of the emphysematous bullous may rupture and may cause pneumothorax, and this will immediately precipitate a respiratory failure. Lung cancer, because the etiological factor for lung cancer is also smoking. So imagine somebody who is fighting with COPD develops lung cancer, the prognosis will become very bad, and respiratory failure. So COPD is pretty bad disease, and it is purely preventable, and early diagnosis will definitely help. I think we should do our best to make an early diagnosis and offer best possible treatment. So prognosis, it's a progressive disease, especially if etiological factors. That completes our second module on COPD, and I hope I was able to give you a good account on this disease, how to diagnose and how to treat. And I really look forward to see you in my next video, which will be on another topic on respiratory disorder. Thank you.